Thanks very much for having me, and it's great to see everybody. And good morning and good afternoon, good evening, depending on where you are. It's great to be here. So what I thought I would do first is I'm required to give a disclosure because I'm going to talk about some of the things that I'm doing, and so any potential conflict of interest we're required to disclose to all of you, and you can have copies of this if you're interested. So what I was asked to do today includes just to begin to talk a little bit about my own global health journey, how I got involved in global health work and where I started and where I've been and where I'm heading. So I'll talk about that a bit and hopefully give you some insights about the different types of careers that people that are interested in global health can pursue. I'll just say a few words about why global health is important to me. After that, I'll talk a little bit about the burden of some of the global health issues and why they're important to me. And then I'll end with just a couple of examples of some recent projects that I'm involved in and that I thought were pretty neat. And of course, to leave a lot of time at the end for questions. So I'm only going to present for a little, a short period of time, and then hopefully we'll have lots of time to answer your questions. So first of all, the journey. It's been a long journey, as you heard. I've got gray hair. I've been doing this for more than 40 years. So it's a long journey. I won't bore you with all the details, but it's been an interesting journey for me and taken lots of twists and turns over those decades. Just a little bit about myself. I'm a Baltimorean. I was born and raised right here in Baltimore, Maryland, where Johns Hopkins is located, but spent most of my career traveling the world and been very fortunate to been able to do that. I got a degree from Haverford College in Pennsylvania in philosophy and chemistry. And when I graduated from college, I took a year off, kind of a gap year, and I traveled to India, among other places, and I ended up working for a leprosy control program, and this is where I started my career more than 40 years ago, working. And this is me from that that time in 1979. You can see I'm wearing a Baltimore's Best T-shirt, and these are two of the patients that I cared for who had leprosy, and I moved on from there, came back to the States and went to medical school up at Dartmouth in New Hampshire. While I was there in 1983, I did an elective. I was really interested in global health after that experience in India, and also did an elective in Pakistan when I was in medical school, and I did some malaria research. That was my first research experience in 1983. The other really, I guess, pivotal experience for me was when I was in medical school. After I got back from Pakistan, I was restless. I really liked the challenges of global health, and decided to do another elective. And this time it was in the United States in a place called Tuba City, Arizona. I don't know if we have any folks from the Southwest on the call, but if you're from that area, that Tuba City is right in the middle of the Navajo reservation, right next to the Hopi reservation, the Second Mesa, and it's a place where the Native American Health Service has healthcare facilities and hospitals. And I did and I worked and lived out there for an elective, and found that a lot of the issues that I saw in Pakistan and in India were affecting people right here in the United States. So I remember vividly seeing communities that lived, people that lived in hogans, traditional housing that was 6 miles from their water source. So it really struck me then that a lot of the issues in global health that I was interested in after my experience in India and Pakistan were just as important here in the United States. And I'll say more about that because that became a theme for my career afterwards. So I finished my medical school training, and then I came back to Baltimore, came home in 1984 to do my internal medicine residency at the University of Maryland. And then I did that for 3 years, and I really got distracted. I loved clinical medicine and ended up really getting interested in critical care and emergency medicine at that time. And I was kind of struggling with my interest in both international global health, infectious diseases, and how fun and how cool it was to be doing clinical medicine. So I took a year and I joined the faculty in the emergency department at University of Maryland, actually. And so I was working in emergency rooms around Baltimore for the University of Maryland. And then at the same time, that same year, I went to Hopkins and did my MPH, my master's in public health, that same year. And that was really when I realized that, you know, as much as I enjoyed emergency medicine, I really wanted to get back into global health because of my experience doing my MPH in 1987. So I stayed at Hopkins after that, and I became what's called a postdoctoral fellow. So I did a fellowship in infectious diseases at Johns Hopkins. It's a 3-year advanced training in infectious diseases. And I focused then on, this is in the late 1980s, and you can remember, well, you wouldn't remember because most of you weren't born then, but back in those days, that was the beginning of the HIV epidemic. The HIV was discovered in 1984. I saw my first AIDS patient when I was in medical school in 1983. And in 1988, when I was doing my fellowship at Hopkins, I started out being interested in doing more malaria research because I had done that in Pakistan. I was really interested in malaria research, and I was actually interested in studying the development of malaria vaccines. I was interested in immunology at the time, but there was no opportunity really to do malaria immunology, but HIV was becoming a big deal then. And I realized a lot of the same issues around developing vaccines for malaria were similar to the challenges in developing vaccines for HIV. So I switched to HIV in 1988, did my fellowship focused on HIV immunology and vaccine development. So remember, I was in India 10 years before that, and Pakistan, 6-7 years before that. But I had been training all those years. I hadn't really had a chance to travel back to those areas until an opportunity arose in 1991 when I was doing my fellowship. I was working on HIV vaccines, and I got a phone call from somebody at the National Institutes of Health, which is the U.S. government agency that funds a lot of research, including global health research. And they said, listen, we're starting a big program to help develop HIV vaccines. And we got a message from colleagues in India. They're interested in applying for this competitive grant, but they need to have not a Hopkins, but a US partner. And we didn't know too many people based in the US who were doing HIV vaccine immunology and had worked in India, but you're on the short list. Are you interested? And so I hadn't really thought about it much. And I was so busy doing, the work I was doing at that point, but I fortunately just said, let's go. So I left Hopkins. I remember going to Pune, India in 1991. And I had 6 weeks to help them pull together a grant application for this big international project. And so I worked with a group in Pune called the National Institutes of Virology, NIV is the acronym. And I helped them write a grant that ultimately got funded. That was called the PAVE grant, the Preparation for AIDS Vaccine Evaluations. So we got that first grant in 1991. We competed with all these other countries, and we were one of the top scoring grants. And that was the beginning of the big project that I started, collaboration I started in Pune, 1991. And we've been there ever since. Hopkins and my colleagues there have been working with folks in Pune since 1991. So right now we've built this big collaborative program there, as well as in other parts of India, and have over 80 projects now with over 180 people working with us in India. So it's been really a big part of my career, helping to build and develop that collaboration. We've worked on everything from HIV vaccines, epidemiology of HIV, the immunology, clinical trials, testing different treatments and drugs for HIV. We've expanded to tuberculosis, to looking at resistant bacteria. You probably heard about the global problem of germs and bacteria that are becoming resistant to antibiotics. we've worked on that. We've got projects focused on mobile health using cell phones and how to improve healthcare with cell phones. We've got projects looking at new kinds of diagnostics, a really broad range of projects, all started with that initial project in 1991. And then once I established that, I brought in a lot of other colleagues to help, and they started their own projects as well. So I had an opportunity back around, well, actually it was, as noted here on the slide, it was, when September 11th occurred, I was actually at a meeting in Uganda. It was my first visit to Uganda, and I was asked if I would help set up some programs there. They had seen what we had done in India. And I happened to be in Uganda when the Twin Towers went down. And that was quite an experience as well. I couldn't get back to the United States. I had to go actually from Uganda to India, stay in India for a while, wait for the flights to open up, fly to Canada before I could even get home. But it gave me an opportunity to start a program in Uganda where I've been working ever since. And that also focused on HIV, mobile health programs, and then also the Fogarty program, which you can see on the slide, is a training program. So one of the things that I've been doing a lot of is training. So I've focused on training scientists from India and Uganda and helping them learn how to do research. And that was a big part of that program. The work that we did in mobile health in Uganda actually led to the development of a new type of mobile health application, a smartphone app called eMocha, which actually now Hopkins has spun off and is actually a company based in the US. So we developed a technology to help people care for HIV patients in Uganda. It's now being used to take care of patients right here in the United States. So it's a really interesting example of technology transfer. We always think of, we in the United States have all the innovations, and then we just share that with the rest of the world. Well, this is the opposite case. This is where the folks in Uganda taught us how to use mobile health technology effectively, and now we're able to use it here in the United States and elsewhere. Really shows how important these partnerships can be and mutually beneficial they can be. And then to wrap things up and bring us closer to where we are today, I expanded my training programs. I got to be pretty busy doing lots of training in Uganda and India, and then got an opportunity to expand the program to Ethiopia. So I worked in Addis with folks in Addis Ababa for many years, setting up a medical education partnership initiative to train scientists in Ethiopia. In 2005, I set up the center that I run, and I'll show you the website in a second, the Center for Clinical Global Health Education that was mentioned. And I've been running that ever since. I'm about to step down as a director and hand it off to two of my colleagues who are going to take over. We've been focused, the mission of the center has been to improve clinical outcomes and clinical care in resource limited settings all over the world. And that's really been our mission. And that includes Baltimore. And we've done a lot of programs, not just in India and Ethiopia and Uganda, but we've done a lot in the United States as well for communities that are disenfranchised and don't have access to we're addressing health equity issues right here in the United States. Then I took a little turn. In 2013, I got asked if I could help build a program at Hopkins called My Diagnostics. And I think I mentioned earlier, I was interested in technology and how to use technology to improve global health. And one of the things we've been working on is new diagnostics. And so we worked on a program. I put together a team at Hopkins of about 35 scientists, and we developed a whole lot of tools that have led to the development of novel diagnostics, what we call point of care diagnosis. Some of you may have heard in the news about this unfortunate company called Theranos. Theranos is a company that worked on a finger prick test. And then it turns out that a lot of the data that they had was fraudulent. And the woman who was a Stanford graduate who founded the company got into a lot of trouble for that. Around the same time she was developing that company, we were working on a related project to leverage silicon chip technology with a group, and there's an expert group working on developing new silicon chips that we use in phones and devices, based in Belgium. And we got them together with our biologists and health people at Hopkins. We actually developed this technology where you can actually do a finger stick blood on a chip. And actually the first commercial application for that, you won't be surprised, is COVID. And the company in Belgium just got approval from the European version of the FDA for their first commercial test. And shown that it works and can give you a PCR, what's called a PCR result in 15 minutes or so. And so they're just beginning to use the technology we developed to develop new tests, not just for COVID, but for lots of things that we designed this to work for things like malaria and other diseases that we think were important. So hopefully that's where they'll take it next. And of course, since 2020, like everybody else in infectious diseases, I've been focused on COVID. I haven't been able to travel much because I'm still a clinician and I was required to stay behind and help care for COVID patients during the surges. We're just beginning now to open up our international travel opportunities again, but it's really, I've still been working on COVID issues in India through the internet and working with colleagues there to develop some programs to look at that. And then I've listed at the bottom, that's a long journey. I warned you, it's been 40 years. So it's a long journey that has brought me to lots and lots of countries. Listed at the bottom, just some of the places I've had the really great fortune to work over the years. But I've also, had great experiences. It's been a really fun ride. On the left is from many years ago where I was working with my friends in Pune. To the left of me, sitting there on the floor, is Dr. Sanjay Mahendale, who he was the deputy director of the Indian Council of Medical Research. He was one of my first trainees, and he ended up becoming deputy director of the ICMR in Delhi. He's now retired from the ICMR, and he runs the Hinduja Family Research Program in Mumbai. And a lot of these other folks are former trainees as well, who are doing great things in India. And it's been a great experience for my family, right? So, I grew up in Baltimore. I don't think I left this region until I was 18 years old and went to college. And so all of a sudden I have this decade-long opportunity to travel the world. I've been able to share that with my family, and particularly my kids, who are now all in their 20s, but this is what they were able to experience that I never experienced as a young person, to travel all over the world, make friends everywhere, have some really interesting experiences. So it's been a really, not just a great professional journey for me, but a really great personal journey as well, and for me and my family. And I've met a lot of great people along the way, and I just want to give a tribute to three of my heroes. These are three friends of mine and colleagues who've worked in global health with me for many years, all of whom died of COVID. On the left is Professor Geeta Ramsey. She was one of the, she was actually, her death was reported in the New York Times very early in March 2020. She was attending a conference in London, and she lived in Durban, and flew home, got sick when she got back from this conference in London, and died of COVID in South Africa. David Katzenstein from Stanford is there in the middle, and he worked for many years in Zimbabwe, doing a lot of the same work that I did in Uganda and Ethiopia and India. And we got to know each other and worked on lots of projects together. And to the left is James Hakim. Professor Hakim and I got to be very close for many years. He was one of the lead investigators doing HIV work in Zimbabwe as well. He and David knew each other, and they died the same week in January 2021, both from COVID. And if they'd been able to survive a little bit longer, they would have had access to the vaccine, and unlikely that any of these people would have died if they had been vaccinated and had an opportunity to be vaccinated. So, I just wanted to give a global health tribute to three of my global health heroes. This is our center website, Center for Clinical Global Health Education. It's about to get a makeover. Probably it looks stale because it's old, but we're going to get a new website and upgrade that pretty soon. But this is where it is now. I'm not going to go through this long slide, but these are just some of the things I'm working on right now. I'll say a bit about something specific here in a moment, but these are all the different projects. I made a list of all the things that are keeping me busy right now. So the good news about global health, and I'll say more about that in a second, is that, it changes. The needs and the opportunities change all the time. Obviously, COVID's a great example. We'd never thought that, we those of us in infectious diseases were not surprised that we had an outbreak of a disease like COVID. But I think we all underestimated how important it was going to be to the world, and so quickly. So you never know in this field what's going to be the next thing around the corner. But it gives me an opportunity to continue to be excited about what, even after all these years, about all the things that I'm able to do and all the cool projects I'm able to work on. I'm just going to say a word about why. So I talked a little bit about my journey. Now I'm going to say a little bit about why I do what I do. And just going to throw some statistics at you that you've probably all heard before. I've been really fortunate to be able to work on a problem that I think is important, and work on problems that I think are important. And global health to me is really important for lots of reasons, but some of the reasons I'm going to talk about over the next couple of slides. One is that, we often forget and don't realize, unless you have a chance to travel the world, that there are more than 3 billion people living less than $3 a day, still today. More than 2.5 billion lack basic sanitation. More than 1.5 billion lack electricity. More than 1 billion don't even have access to water that they need, including people, as I mentioned, in the Navajo reservations of the United States. And despite all of our advances today, a poor child still dies every 4 seconds in the world. And so this problem continues to be a huge burden and a hugely important problem. And I think it's really wonderful that there are young people like you who are really interested in continuing to work on this kind of a problem, because we haven't solved it. After 40 years, people like me haven't solved it. There's still a huge need and a lot more to do. And so we need people like you to get interested and help us continue to address some of these tough problems. The other thing that I wanted to emphasize again is that, global health is local as well. And I mentioned that, the global health issues, the equity issues and the access to care issues we worry about in sub-Saharan Africa and in Asia apply right here in the United States. And this, I'm going to use some examples to illustrate that point as well in a second here. But I just, for conversation's sake, I listed on the left, this is data from 2019, the average life expectancy in years. And you can see on the left are the top 10 countries. In fact, there's a misspelling there, Liechtenstein. Sorry for the misspelling at the bottom of the slide. And on the right are the bottom 10 with the lowest life expectancy. And we are in the United States not even close to the top. We're right in the middle with a life expectancy right now that's in 2019 it was 79. Does anyone know what it is now? It's closer to 77. Does anybody know why? COVID. COVID has reduced the life expectancy in the United States by almost 2 years. Now remember, life expectancy is a measurement of health. It's been going up for decades and decades, for hundreds of years because of improvements in health. All of a sudden, COVID comes in the United States and it's dropped 2 years, even more, closer to 3 years if you're African American, Black American, or Hispanic, closer to 2 to 3 year drop in life expectancy within 2 years. Incredible impact on life expectancy. And that's true all over the world. The other thing that I mentioned is that global health changes all the time. And this just illustrates that. On the left are the top 10 causes of death in 2000. And on the right, 20 years later, the top 10 causes of death. And, just take a look at number 8 for a minute on the left. That's AIDS. Now, that's just back in 2000, before we had access to a lot of the drugs. And you can see now AIDS has dropped down to number 19. because we've had access to treatments. But what's going up? Look at Alzheimer's disease. Went from 20 to number 7 in the world. Dementia is a cause of death. Look at COPD. This is from smoking and air pollution, moving from 5 to 3. A lot of the chronic diseases, lung cancer going up, diabetes going up, kidney disease going up. And then what's going down are the infectious diseases, diarrheal diseases going down, TB death rates going down, et cetera. So things have changed just in 20 years. It's also changed in my field, infectious diseases, and this is an illustration of that. This is from a paper in the journal called Lancet from a couple years ago. And they looked at the annual deaths from different infectious diseases. This is based on 2016 data. And they looked at the trends and projected where will we be in 2040. And so if you're on this call and you're interested in global health and infectious diseases, I would encourage you to be interested in a disease called hepatitis, viral hepatitis. We have lots of different kinds of viral hepatitis in the world, but the hepatitis B and hepatitis C viruses are the most common in the world. And there are going to be more deaths from hepatitis in 2040 than the combination of deaths from TB, HIV, and malaria. And so while those death rates are declining because we have treatments, the death rates from hepatitis are going to continue to rise. So things change. And, I think that's both a challenge and an opportunity for those of you that are interested in global health, is to think about that. The other big issue in global health course, or one of the many, is maternal mortality. And so women who deliver babies are still dying at a rate of more than 800 every day in the world. And 15% of pregnant women develop life-threatening complications. Even if they survive the delivery, complicated delivery, they can have really significant complications after delivery. About 3% of all deliveries require a major intervention to prevent the mother from dying. So think about all the communities in the world, like the one illustrated here. This is a picture I took of a woman who's got a little baby on her lap, plus another child. Had delivered both of these babies in this village with no attendant, no birth attendant. So she's fortunately survived. The babies look healthy, but she was at great risk. And people like her continue to be at great risk, because if they don't have access to care and she has a complication, she and the babies are in big trouble. And for every maternal death, there are 30 to 50 cases of serious morbidity or complications from those deliveries. So it's a huge problem, but we've made some progress. And this shows the decline over time in just using 2 countries as an example, but this is true all over the world. So in places where they've been able to improve access to what we call skilled birth attendants, these will be like midwives that can help come to your home and deliver the babies. It has a dramatic impact in reducing the risk of death for the mothers. And you can see examples of that from Uganda and Rwanda there on the left. But I show this slide also to remind us again that global health is local. What this slide shows is the maternal mortality. This is the number of pregnancy-related deaths per 100,000 live births. And it compares different countries. So you can see that USA has a number of 19, on average, 19 pregnancy-related deaths per 100,000 live births, which is worse than Russia and Turkey, Iran, Kazakhstan, almost twice as high as Canada, almost 3 times as high as the UK. And why are we have such a high mortality rate compared to these other countries? And it's shown here on the left. This is the data from my own state of Maryland. And you can see the blue line across the top is the pregnancy mortality rate for Black Marylanders. So you can see the blue line is your mortality rate if you're pregnant in Maryland. It's close to 30. Now the US average is 19. The red line is if you're a white pregnant woman in Maryland, much, much lower. So the average in the United States, this tells you where the average is. But the rates of maternal mortality for Black Marylanders and Black women who are pregnant in the United States is just unconscionably high. It's on par with Syria and Uzbekistan, as I show, for example, here, which has got a rate of 31 and Uzbekistan at 29. It's just unconscionable that we have this kind of disparity right here in the United States, highlighting how important it is for those of you interested in global health. And you don't have to look too far from your own homes to see important issues like this that need attention. What about child mortality? Again, we've made some progress. If mothers are healthier, babies are going to be healthier. And so we've seen declines in the death rate in children over time, significant declines. And these are just some examples. And that's because we've been able to improve safe deliveries and improve the health of moms so that their babies are more likely to survive. Let's take another look at Maryland again. You could look at these data in your own state, in your own countries, to see how you compare. But the United States child mortality rate, the infant mortality rate, which is the number of deaths per 1,000 live births in kids, is 6 on average. 6 deaths, 6 kids for every 1,000 babies delivered, 6 of them will die within the first year in the United States. So it doesn't sound like a large number, but compare it to the rest of the world. Our rate of 6 is on par with Sri Lanka, Lebanon, worse than Russia and Cuba. You can see UK, Estonia, Sweden, Japan, one of the safest places in the world to deliver, to be born, as a rate that's 2 compared to 6 per 1,000 in the United States, 3 times higher. But again, look at the disparities on the left in Maryland. You can see the green line is the child mortality rate in Black Marylanders is around 10, which is higher than the national average of 6 compared to other communities in Maryland. So that death rate puts them on par with El Salvador, Libya, Peru, Malaysia. It's just unconscionable that we have this kind of disparity in a country as wealthy and as fortunate as we are. Again, I hope this makes you angry, and I hope it also encourages you to think about why it's important to continue to pursue careers focused on global health and health equity issues. So I'm going to ask a quick question. Can we get people to answer? Are they able to answer? Can they type in some answers? We get a sense for what people think the answer to this question is.
Yeah, students, go ahead and type your answer into the chat.
Yeah, type your answer in the chat. Let's see what we think. What are the following countries has the highest prevalence of hypertension or high blood pressure? Which country has a higher percentage of their population with hypertension? U.S., India, or Uganda? I'll let Simon let you.
Sure. It looks like almost everyone has said the U.S.
Okay. Good. Anybody want to know what the answer is? It's a trick question. It's all about the same. So multiple studies have shown in adults in the United States, India, and even in rural villages in Uganda now, the rate of hypertension is about 29%, 27%. It's pretty similar in all countries. Again, illustrating that, that the slide I showed you earlier about the change in the causes of death, things like hypertension and diabetes are increasing in places like India and Uganda. Same thing with diabetes. The rates of diabetes in the United States, India, and Uganda in adults are about the same currently. And so you don't have to be interested in infectious diseases to be interested in global health. If you're interested in virtually anything on any medical issue, you can find out reasons why it's important to global health. So these are examples of what we call non-communicable diseases, non-infectious diseases, things like diabetes and cancer and cardiovascular disease, heart attacks. So 2/3 of all of the non-communicable diseases, we usually think of, and I think this group reflected that, we think that that the United States and the wealthy countries are places where the greatest burden is of hypertension and diabetes and heart disease and cancer. But it turns out that 2/3 of all these deaths from these diseases occur in low and middle income countries. There's lots of reasons for it, and we can talk about that later if you want to ask some questions about that. But 4 conditions account for over 80% of all these deaths: heart disease, cancer, respiratory diseases, like we mentioned what's called COPD, and diabetes. And the key factors are obvious: air pollution, hypertension, tobacco use, alcohol, and lack of physical exercise, which is an issue all over the world, not just here in the United States. So that's just an overview of some facts that I hope that certainly keep me interested in global health, but I hope also keep you as well. I have somebody outside the door here. I'm just going to mute for a second if I could. Yeah, hopefully they'll cut down on some of the background noise. So this is a list of some, if you're interested, I'm going to share this with you. This is a list of some websites that I usually like to look at with some, that if you're interested in looking up some of these statistics on your own, or maybe from your own country, to see where you fall on some of these lists. These are some resources. If you're interested, you can check it out. So I got another question for you. Which country spends the highest percentage of their gross national income? That would be if you count up all the money in a country, the gross national income. Which country spends the highest percentage of that on foreign aid, including global health?
So far, about, let's see, maybe 80, 90%, maybe 95, almost all the students now are saying Sweden. A few students are saying UAE, UK, and the US.
Great. Well, it turns out if you actually look at the absolute number, absolute amount of money, the US is number 1, shown here on this slide. But if you look at the percentage of the GNP, we're way down the list. And up here at the top, believe it or not, is Turkey. And you can see Sweden is up there too, Germany, UK. We were way down the list, and we're not even close to the top 10 or top 20 as far as the percentage of our gross national product that we actually spend on global health and foreign aid. But we still are the number 1 donor. It raises some interesting ethical questions for those of us, and political questions as well. If you think that global health is a national security issue, for example, you see what happened to the world's economy and our own economy because of COVID, which was a global health issue. It makes you begin to think about, what do we need to do, if anything, to help reduce the risk, not only to the world, but to our own economies and our own health by investing in global health. So I'm just going to wrap up with just mentioning a couple of projects I've been working on recently that just to illustrate some really, I think, other examples of why I love what I'm doing. So I'm just going to talk about 2 projects. And both of them are TB projects in India. Both of them involve 2 young investigators that I've been working with and training over the last couple of years. And examples of things that it was a huge effort for them. It took many years for them both to develop these projects, to do the analysis, to write the paper. And I have to admit, I tortured these poor guys to help them write their papers and get it done. But after they both got them done, both of these papers have had a huge impact. They're actually, both papers are having an impact in changing the guidelines for how TB is cared for in India and beyond. And when they were beginning this process, I've told them this is delayed gratification. Global health is delayed gratification. You got to work hard for a long time before you see an opportunity to have an impact. But when you do, it really reassures and I think makes them feel good about what they're doing. And I'll just give you 2 quick examples. This is Mandar Paratkar, who works in Pune, and he was studying the fact that, if you have a patient with tuberculosis, first of all, I don't know if you all are aware, is until COVID came, TB was the number 1 infectious disease killer in the world, even more than HIV. And 1/3 of the world's population is infected with the TB organism. Now, most of them have what's called latent TB. You know, the TB is dormant inside their systems, and if they were to get sick as they get older, the TB can resurrect itself and cause problems in the lungs, which is what you typically hear about. But it's transmitted. It's transmitted through the air, just like COVID. It's a respiratory disease, and so if you have a TB patient in your household, everybody in the household is at risk. And we have treatments not only to treat TB, but we also have treatments to give to people who are exposed to TB in the household. But a lot of countries just have a difficult time justifying the expense and the need for that preventative treatment. And that was the issue that Mandar was interested in. So he did a study that looked at the households. He studied the people, the kids and the other adults that lived in a household with someone that had documented tuberculosis. And he asked the question, which of those people would benefit most from getting this preventative therapy? Because a lot of the recommendations in India were to only give it to, for example, young babies. Don't give it to everybody in the household, or give it to only people that had a positive skin test on, you know, for TB in the household. And what he showed is that everybody in the household, regardless of their skin test, regardless of their age, regardless of their risk factors, was at risk for TB, had equal risk for TB, and would benefit. And this is now being discussed to change the guidelines in India to now make the guidelines in India more consistent with other countries, which recommend, like we do in the United States, treating all contacts. Here's another example. This is Vijay from Chennai. He's another one of my colleagues, young colleagues working in Chennai. He just published a paper on something called extrapulmonary TB. So some people that have TB, as I mentioned, most of them actually get it in the lungs, but there's some people, particularly young kids, for example, and even some adults who don't seem to have it in their lungs. They get a skin problem, they get a swollen lymph gland under their arm or in their neck, or they get infections elsewhere in their body. And if you do a chest X-ray, the chest X-ray looks fine. And they don't have any symptoms, they don't cough, they're not short of breath. And so for many places, including at Hopkins, the assumption was that people that have extrapulmonary tuberculosis and don't have any symptoms and have a normal chest X-ray, that they're not infectious to others. So you treat them, but you don't have to put a mask on them and isolate them, because they're not likely to spread it to others because it's a respiratory disease. And the thought was, well, it's not in the lung, so therefore it's not likely to be infectious as regular TB is. Well, he proved that that was wrong. He did a study of hundreds of people with patients with extrapulmonary TB, and he took sputum samples from all of them, regardless of their symptoms. And he found that among those who had a completely normal chest X-ray and absolutely no symptoms of lung disease, 14% of them actually had the TB bacterium in their sputum that nobody knew about. And so he published this paper a few months ago, and I think since that time, there was another paper that came out showing exactly the same thing, I believe, from California. So he was the first to show that this is a big problem to be concerned about. And now they're even thinking about changing the guidelines for how to isolate and protect not just household members, but healthcare workers when people have extrapulmonary tuberculosis. Again, he worked for many years on this project. I think I had him do about 10 or 15 different revisions of this paper over a period of time, but he finally got it published and accepted. And in fact, he just texted me the other day that the paper is getting highlighted as one of the top papers that's been published in this journal, one of the most important papers published in this journal. And so he's really excited about that. So I hope this gives you a little bit of background about myself, about why I'm interested in global health, and projects like this that, you know, continue to get me interested in helping people like Vijay and Mandar and others continue to work on these important problems. And with that, I think I'm going to stop, hopefully given plenty of time for questions, and would welcome any questions you have, not only about what I've talked about, but anything to do with global health. So hope that was helpful.